Step into the illuminated dark room where I shine a light on breast-related topics and beyond. I'm Dr. Ify a general radiologist with over 20 years of experience in breast imaging. In this podcast, we'll explore the diverse and unique patient journeys, share insights, and empower listeners with knowledge. Join me as we dive into candid, real conversations that illuminate the path to better breast health. All right, how are you?
I'm doing wonderful. How are you?
I'm good. Thank you. I'm so excited to have you here. So let's just get started. This episode, it's centered around the discussion of perimenopause and menopause in a very practical and simple manner. So I'm excited to have an expert in the field here, Dr. Shafeena Premji. And I'm going to introduce you before we start our discussion, okay?
Sure, absolutely.
All right. So I'm going to do that by reading your bio. Dr. Shafeena Premji is a mother, daughter, wife, artist, which I have to remember to ask you about, an entrepreneur, a passionate and dedicated women's health advocate, and a menopause specialist in Calgary, Alberta. She's a family physician with a fellowship designation with the Canadian College of Family Physicians and in women's health. She holds a Menopause Society certification since 2015. She's the founder and medical director of 3 medical clinics, Mahogany Medical Clinic, The Village Medical, and her most recent venture, Milestone Menopause Center of Southern Alberta, which launched in March 8, 2024. Dr. Premji serves on the board of directors of the Canadian Menopause Society and the medical advisory board of the Menopause Foundation of Canada. She has made media appearances advocating and enlightening menopausal women across the country on CBC, the National CBC Radio, the Toronto Star, the Globe and Mail, Those Podcasts, and Dr. Brian Goldman, as well as Yahoo Canada and Chatelaine Magazine. She also speaks widely at the conferences, educating students, residents, and her colleagues. When she isn't working, she loves spending time with her precious boys and her husband, lifting heavy weights, or listening to personal mastery podcasts from her mentor, Robin Sharma. So thank you for being here. It's an honor to have you.
I'm so honored you've asked me to come and be part of this inaugural podcast. It's amazing the work that you're doing for honoring women and validating their health experience and giving them an opportunity to really understand and explore their own health and be CEOs of their own health. So
Yes,
thank you.
Oh, you're welcome. I think that is so important right now. It's so key, right? Yeah. When I read your bio, there was a lot. I said menopause a lot, right? So I love that you're an expert. But before we delve into it, can you tell me? I always ask people, what Shafeena Premji? What does your name mean? Your origins.
Oh my goodness. I think my name means like a boat full of gold, actually.
Oh, I
I
love it.
Yeah, I think that's what my name means. If I remember correctly,
We'll go
yes.
with that.
Okay, it's a boat full of gold.
I love it. That's amazing. That's amazing. I always ask people that question because I'm from Africa, so names have meaning, right? And I'm always amazed at.
It was interesting when I was first born. My name was Nadia, and I was
Oh.
Nadia for 2 weeks.
Oh.
2 weeks, and then my parents somehow decided to change my name. I don't know why. I don't know how.
Well, they did right. Because you're boat full of gold. It's all good.
I will amen to that.
Yes, amen indeed. Yes. Okay. So can you just walk me through how did you decide to get into family medicine and now you've segued into women's health and specifically menopause? What was your journey and why?
I think all of us in medicine have very interesting, not linear pathways into our career and into our subspecialties. But when I was actually in grade 6, I developed a really bad skin infection.
Mm-hmm.
And it was sort of spreading all over my body. I had seen a family doctor. I had seen a pediatrician. I had even seen an infectious disease specialist, and nobody could figure out what was going on with my skin. It was actually almost 3 months in when I had literally my skin was scalding and it would burn in the shower. I had like these big papules and breakdown of skin all over. And I remember we had gone to the emergency department because I was in so much pain.
Mm-hmm.
And a pediatric ER doctor brought out a dermatological encyclopedia and sat down with my mom and dad. And I still remember this. And he somehow figured out what I had, and he decided that I had impetigo, which nobody had ever identified because usually impetigo is on the face, especially in children, and mine was not on the face. It was on my arms and legs. And after 3 months of suffering, I was finally given a very, very strong dose of oral antibiotics,
Mm-hmm.
which treated the infection. But then I had ongoing scarring for almost 2 years from just how bad the skin breakdown had been. And that moment with him in the emergency department, he actually changed my life.
Mm-hmm.
And I think that's what really prompted me to say, I want to be a doctor one day and I want to help people. And I know it sounds very cliche, but I think that's where it all became apparent to me.
Yeah, that's amazing.
And I initially thought I wanted to go into pediatrics. So when I, went into medicine and started doing electives in pediatric medicine, I realized that that was actually not an area that I was comfortable in. It was
Mm-hmm.
really, really difficult for me to see sick children all the time. But I still had this passion for moms and babies and just women. Like I loved being
Mm-hmm.
a girl when I was young. I used to wear fashionable clothing. I used to dance. I loved wearing makeup. Like I just loved being a woman or a girl. And so I
Yes.
was like, this is great. There's an area of medicine which feeds onto my already underlying interest. So
Yes.
that's kind of how the whole idea about women's health came in. And then I actually ended up shadowing a family doctor who did obstetrics. I love the whole idea of newborn care and deliveries. And that's kind of how I got into the whole idea of women's health. The menopause piece really didn't play into my whole journey until third year of residency when I
Okay.
was doing a women's health fellowship at Queen's University. And I was at a clinic in Ottawa where there was a multidisciplinary floor offering pelvic care, a urogynecology, a vulvar clinic, and a menopause clinic.
Mm.
And so I ended up being in the clinic of Dr. Elaine Jolly, who at the time was the first president of the Canadian Menopause Society. Nobody had said the word menopause to me throughout my training. It's like you talk about women's health in terms of contraception, birth
Mm-hmm.
control, pregnancy, fertility, labor and delivery, postpartum, breastfeeding, and then that's it.
Yeah,
There's nothing
done.
else. You're
Mm-hmm.
done. You figure it out, right?
Yeah.
So when I began to understand that there was a whole other underserviced area of women's health that nobody had addressed, and how beautifully and eloquently this doctor was providing this care, and how grateful the patients were in receiving her care, she said to me, if you really care about women's health, you need to understand menopause and how to support these patients. And so I went down the journey of being my mentor, and
Mm-hmm.
I attended the first Menopause Society conference in LA. And really, my journey after that kind of, became more and more solidified as I began to learn more about menopause, hormone therapy, how underserviced this area of women's health was, how much need there was, and attending more and more conferences, my interest, my learning, my education just grew. So that's really my journey. And the more I do it, the more I begin to realize even more so how needed this is for so many women across our country as well as worldwide.
Yeah, no, for sure. Thank you for that. And I love that you said all that because, yeah, it's something that I don't remember learning in med school. It's not something that's spoken of a lot. And yet, there's one of the reasons why I wanted to do this is you look at social media, it's everywhere.
Mm-hmm.
They're self-proclaimed menopause experts. We have a World Menopause Day now, October 17, I think it is, right? And so it's everywhere. And women need that information. It's so key. I think it affects our lives so much. So
Mm-hmm.
I thought, and then, when you look at some of the information out there, it can be so complex and hard to understand.
Mm-hmm.
So I wanted to do this and talk about it in a very simple manner. Let's take it back to the basics. So let's help our listeners out there understand what it's about, right?
I love that. Thank you.
Yeah, for sure. Okay, so um, I want to start by let's go back to the basics. I think when I think of menopause, a woman's cycle, there's three hormones that we think about, right? Estrogen, progesterone, and testosterone, right?
Mm-hmm.
Which may surprise people. Women, testosterone, what? So can you explain how like these hormones are related to women in general? What role do they play in women's lives?
So you're correct in that there are three main hormones, but our bodies make several hormones,
For
not
sure.
just those three as
Mm,
well. And really, our reproductive life begins in puberty when we have the pulsatility of the GnRH hormone that comes from the hypothalamus, which starts to pulse essentially. And that pulsatility then triggers the pituitary gland to release another hormone called follicular stimulating hormone. And follicle really is an immature egg in our ovary. So there's a hormone from the pituitary gland called the follicular stimulating hormone, or FSH, which tells our ovary to wake up and release an egg, or at least help mature an egg. And so that pulsatility of the GnRH, which comes from the hypothalamus, then has a conversation with the pituitary gland, which then has a conversation with our ovary. So we call that the HPO axis, if anybody really wants to know the medical terms:
Mm-hmm.
hypothalamus pituitary ovarian axis. And that's what really gets everything kind of revved up. And every month, once this cycle has sort of kicked into place and has started, essentially our body is trying to prepare for a pregnancy every month. And so with that process, there is an increase in estrogen. Eventually, in the middle of the cycle, there is a second hormone from the pituitary gland called LH, or luteinizing hormone, which happens a kind of a surge or a peak middle of our cycle, so around day 14. And
Mm-hmm.
that triggers one of the mature eggs from our ovaries to be released and then enter into the fallopian tube to wait for fertilization. And we have a small window of opportunity for when we can then conceive and get pregnant.
Right.
And at the end of the 28-day cycle, if there has been no sperm that showed up, we essentially have an unfertilized egg. We have a buildup of a uterine lining that was waiting to potentially have an embryo embedded. But if none of that happens, we essentially shed the lining at the end of every month. So that is kind of how the estrogen cycle kind of works. The progesterone piece really plays into the second set of the cycle, where it's helping to build up that lining, to stabilize that uterine lining, to help prepare for a pregnancy. So then at the end of the month, when there is no pregnancy, all your hormone levels drop, you bleed, and then the cycle starts all over again. Testosterone comes from several different places. It comes from the ovaries, it comes from the adrenal glands, and it comes from our subcutaneous tissues as well. So there's a very multiple levels of where the testosterone level comes. And interestingly, throughout our life, testosterone levels actually stay pretty stable even throughout our reproductive life, and even through and into menopause. And it's really only until we are in our 60s that we really see a drop in testosterone levels. So that's why it's really hard for us to use a testosterone level to get an idea whether we have an adequate amount or a non-adequate amount. And also, some testosterone is found in the bloodstream and some is found in the tissues. So
Mm-hmm.
when you're doing a blood test for a testosterone level, it's only measuring what's in the bloodstream. So there is no perfect blood test to determine what our testosterone levels are.
Interesting. Okay. So to break it down a bit more, I think people think of progesterone as a feel good hormone,
Mhm.
right? And that's the latter part of the cycle. Estrogen, what exactly does it do for us? Like, how does it make us feel? Is it cognition, our heart, what?
Well, if this is a surprise to the listeners, we have estrogen receptors in our entire body,
Right.
head to toe. So
Joints.
it is doing a multitude of things for us. And until we don't have it, we don't realize how valuable our estrogen levels are and our estrogen that our ovaries are producing are. But it's
Mhm.
also important to know that we actually produce four different types of estrogen, and they're numbered: E1, E2, E3, E4. So E1 is called estriol, and that comes when we are pregnant. So we produce high levels of estriol when we're pregnant. E2 is estradiol, and that comes primarily from the ovaries, and that's the most potent form of estrogen and the one that we all hear about.
Mhm.
The third form of estrogen, E3, is called estrone. That comes from the adrenals generally. And then there's E4, which is estetrol, and that's pretty new to medicine nowadays. But estetrol is actually found from the liver of a fetus of a pregnant woman.
Hmm.
And estradiol is the main one that we are referring to because it's the most potent one. So when it comes to our entire body systems, all of our organs, we have estrogen receptors throughout our brain. We have estrogen receptors in our hair, in our skin, in our nails, in our breast, in our bones, uterus, vulva, vagina, urethra, bladder. Like it's literally
Everywhere.
everywhere. And
Yeah.
so when we go through menopause, this is a multi system neuroreproductive change. And so we have to be aware of that. This is not just about our ovaries and periods, this is about a whole lot more. And to be able to identify all of this can sometimes be really difficult, or it can be misinterpreted as being something else when it really
Yeah.
is all related to one thing, which is the perimenopause or menopause.
Yeah, no, that's great. It's good you explained it that way because when you think of the symptoms, it makes sense now why it affects so many different parts of our bodies, not just, like a reproductive, effect, right? So,
Mhm.
yeah, I love that explanation. So, to that effect, what is perimenopause? And when does it start? How long can it last? What triggers it? All that.
Right. So when we are born, we all have a certain number of eggs in our ovaries. And essentially, menopause occurs because of aging of the ovary, but also because there is a loss of ovarian function because we no longer have eggs in our ovaries. So there's
Hmm.
a finite number of eggs. If you can imagine, women or individuals born with ovaries have the highest number of eggs in our ovaries when we're actually a fetus inside of our mother. When we are born as a newborn, we have around anywhere from 400 to 600,000 eggs or follicles in our ovaries. Into puberty, it goes down to about half, so 200 to 300,000. And really, by the time we hit into menopause, we have maybe less than 1,000. An average woman ovulates about 400 times in her lifetime. So, what happens to all those other thousands and thousands of eggs?
Hmm.
They are lost just through natural aging processes. So we call that attrition. So, menopause really occurs when we are no longer capable of ovulating or getting a period because we no longer have an adequate number of eggs left in our ovaries. The average age is around 50, 51, 52, depending on which country you refer to. And perimenopause is the havoc that occurs before that final period. And that havoc, that fluctuating hormone levels, the ability to ovulate and not ovulate, and ups and downs in hormone levels all over the place, is a 4 to 7 year transition. So it doesn't happen where it's like start and stop. It start, stop, start, stop, start, stop for
Like a
years
roller
and years
coaster.
and years. It's a roller coaster of symptoms, hormone changes, and health changes that occur in that process. So if a woman is in her late 30s or even early 40s, she very
Mhm.
well could already be in perimenopause. And even though the average age is 51, the range can be between 45 and 55.
Okay, so it's a big range. Okay, can you talk about some of the symptoms
Of
of
course I
perimenopause?
can.
Yeah.
Yeah, so, we think that perimenopause is just a change in menstrual cycles because that's, again, we think periods, fertility, menopause. But as I mentioned now, it's an entire multi-system change. And so I kind of think about the symptoms in groups based on organs. So in the brain, there's a number of symptoms that occur. The most common one that we know about is those hot flushes. And now
Hmm.
we actually understand the pathophysiology of how the hot flush occurs. It's an area within the hypothalamus where there is a special set of neurons called the Candy neurons. And it's a disequilibrium of the Candy neurons that actually triggers heat dissipation from the skin that causes us to feel hot when we're actually not. So the core body temperature doesn't change. So that's the one symptom. The second symptom is the mood disturbances and mental health changes. And we know that for women who've had a previous history of depression or anxiety, postpartum depression, PMS, these women actually are much more symptomatic during perimenopause and are more likely to have mood changes. The third thing is sleep disturbances. So this can be presented in many different ways. Some women have difficulty falling asleep. Some women have early morning awakenings. Some women have several awakenings throughout the night. And it can be for no reason. It can be because she has to go to the bathroom, or it's because she's having hot flushes. And the third thing is the brain fog or cognitive changes. And the brain fog for women in perimenopause generally presents as verbal memory recall difficulties. So they cannot remember why they walked into a room. They cannot remember where they put their keys. They can't remember somebody's name. They're mid sentence. They can't remember a word that they're trying to say. So
Mm-hmm.
it's verbal memory recall. That's the challenge for the majority of women. This actually does not indicate a risk of dementia. So I really want to emphasize that that is not something women generally need to worry about. So that's the brain changes. Then we've got hair, skin, and nails changes where that, you can change, hair becomes thinner. You may have drier skin, loss of collagen. Some of this is natural aging. Some of it could be lifestyle, and some of it could be hormonally mediated as well.
Mm-hmm.
And then in terms of the pelvic area, the genitourinary symptoms, women will report increasing dryness in the vagina, lack of lubrication with intercourse, pain with intercourse, increased frequency with going to use the bathroom more often, and also incontinence and even more frequent awakenings at night to go to the bathroom.
Mm-hmm.
There are also cardiometabolic changes, meaning women are reporting a change in their body habitus and an increase in mid-abdominal weight gain. And that can happen because of several different factors playing in. Some of it can be because of the loss of estrogen and its benefits on insulin sensitivity. Some of it can be because of a drop in energy expenditure and an increase in food intake.
Mm-hmm.
So there's a whole host of things happening at the same time. There are many other symptoms that women may or may not report. There's palpitations, there's migraines, there's generalized fatigue. Um,
I've
I
heard of
think
ringing of the ears or itching
itching of
ears.
the ears. I mean, some of it is truly well understood and defined, and some of it we still don't fully understand why.
Yeah, interesting. That's a lot of symptoms, you know.
That's a long-winded answer. Sorry.
No, no, it's great. I mean, gosh, Shafina, I love you are so eloquent. I love and how you explain things. It's just amazing. So thank you for that. Now, when you think about these symptoms, and I feel like for most people, life is getting harder. There's challenges of daily life. How do we know that some of these symptoms aren't just related to that? Everything can't be because of when perimenopause or menopause. How do you separate the two? If you go to see your doctor, how do they separate the two? How do you have that discussion and determine, okay, this is menopausal, perimenopausal versus not?
Sometimes it can be very difficult to tease that out. And one thing I always do with all of my patients when I meet them for a consultation is I do ask a lot about their social history. And I do also ask a lot about their current life stressors. And I
Mm,
specifically ask, are there other things going on in your world? And oftentimes I'll get very, very varied responses. So it'll be parents that are aging. It could be a teenager that's struggling with their own mental health. It could be a young child who might have type 1 diabetes and you're waking up worrying about their blood sugars in the middle of the night. It could be work related stress. It could be financial stress, or it even could be relationship stress. So these women who are in the prime of their careers are also having to juggle so many competing demands. And it's very difficult to tease out what is hormone and what is life.
right,
And sometimes you can figure it out based on the time frame when the symptoms begin, but sometimes you can't. We know that the hallmark of hot flushes is very indicative. So if you are also having hot flushes in association with all of these symptoms, you're more likely to assume that the symptoms are hormonally driven. But if a woman has just irritability and just sleep disturbances, sometimes it's difficult to tease out what is what.
yeah.
And in Alberta, sorry, I guess really in Canada, the
Mhm.
indication for treatment with menopausal hormone therapy is really for vasomotor symptoms, so the hot flushes and night sweats. But if you look in other places, as well as the International Menopause Society, their definition of what would be indicated for hormone therapy is a lot broader. So they do consider sleep, mental health, mood, brain fog symptoms also a part of an appropriate patient who may consider hormone therapy. So, what I do tell my patients, if we don't have 100% certainty, is that, you know what, let's try hormone therapy. You are an appropriate candidate. I'm not going to deny you hormones if you
Mhm.
are an appropriate candidate, and maybe this is hormonally driven. And we have really good evidence that perimenopausal mood changes can be treated with hormone therapy as effectively as an antidepressant. So what I do, I find a regimen that works for that woman. I prescribe it to her for 3 to 4 months, and then I get her to come back into the office and reassess her symptoms. I will reassess her mental health by offering her a couple of questionnaires, an anxiety questionnaire and a depression questionnaire. And I also assess her sleep and her overall quality of life and day to day function. If things seem to be improving, there's my answer.
Mm-hmm. Okay.
Sometimes there's some improvement, and we still need to entertain. Maybe she's got sleep apnea. Maybe she's got chronic insomnia. Maybe
Mm-hmm.
there isn't a component of depression here. So we add, an antidepressant in that regard. So things are not exclusive either. There can be overlapping things going on at the same time. But what I really want to stress to your listeners is that it's important that when we see patients, we have to look at them um,
As
holistically
a whole, right?
and understand that it's not an easy fix. Hormone therapy is very effective for the things we know it has evidence for, but we still have to think about our lifestyle, how we're managing our life in terms of stress and sleep and our workload, and just
Mhm.
making more time to make ourselves a priority. I really emphasize to women that even though I'm here to prescribe you hormone therapy and validate your symptoms, this is also an opportunity for you to reassess your life, reassess your priorities, and not feel guilty about making yourself priority. Because as women, we always seem to neglect that. We always put ourselves last. And I really want to help women understand it's okay to be selfish. It's okay to want
Mhm.
to take care of yourself, because when you are well and you feel whole, you can deliver in every other aspect of your life much more effectively.
Yeah, no, that's great. Yeah, I'm glad you mentioned that. And now we're on the topic of hormone replacement therapy, which
Mhm.
this is an interesting one because, for a long time, women have been told, well, hormone replacement therapy, breast cancer, we have breast cancer patients. Obviously, a lot of the breast cancers are hormonally driven, and a lot of women out there suffering and not wanting to go on hormone replacement therapy because of that thought, right? So, can you talk about hormone replacement therapy, some options, and how important it is? And I think you've touched on it a bit in managing the risks, in managing these symptoms.
So, hormone therapy and the history of the fear around hormone therapy is a long, long conversation. We could
Yeah.
talk another hour on that. But to keep things really clear and short and concise for the audience today,
Hmm.
what I really want to emphasize to women is that there is a window of opportunity for where hormone therapy is considered um, likely more beneficial than risky. And that window of opportunity is for women who are under the age of 60 to when you initiate hormone therapy, or within 10 years of that final period. So 10 years of your menopause. When we look at that women's health initiative that increased that concern around breast cancer and other chronic medical conditions, as well as heart disease and stroke and blood clot risk, what the challenge with that data is that they clumped all of the women between the ages of 50 and 79 into one demographic. But
Hmm.
when they re-stratified the data and looked at women in their 50s, 60s, and 70s, they understood that it's the women in their 50s who actually get benefit, and it's the 60 and 70-year-olds who may have higher risk of these complications. So that's the first thing. The second thing is that when we talk about hormone therapy, you have to ask it in the context of whether you have a uterus or whether you don't have a uterus, because the form of hormone therapy is different. If you have a uterus, it's estrogen and progesterone. If you've had a hysterectomy, it's estrogen alone. When we look at the Women's Health Initiative data, women who have had a hysterectomy who use estrogen alone, there's actually a decrease in breast cancer risk. And it's women who are on both estrogen and progesterone, the combination, who have the higher risk of breast cancer. But when we put the risk of breast cancer into context, the number one risk for breast cancer is, as you know, the BRCA1 or 2 mutation. The second highest risk is having dense breasts, even more so than being on hormone therapy. And then family history, obviously, with the first degree relative, is also another risk factor. But hormone therapy falls much lower in that risk category. The other thing I want to say about breast cancer risk is that a woman taking hormone therapy and the worry about breast cancer risk is also equivalent to having a BMI of 35 or using and drinking 2 alcoholic units of alcohol per day. So our lifestyle also
It's a
implicates
huge part.
breast cancer.
Yeah.
And I feel very confident in prescribing hormone therapy to women, even if they have a family history of breast cancer and even if they have dense breasts. But we have options which may be more safer for that woman.
Right. So I always tell, I think of breast cancer, I say the biggest risks are being a woman and aging.
Hmm.
Like we can't prevent it. We can do our best to be in the best possible health that we can be. But,
Hmm.
and I'm also hearing from you, and correct me if I'm wrong, the earlier, like it's hormone replacement therapies, it offers more protection or more benefits if you take it earlier versus, let's say, when you're 60, 70, when you're looking at that risk of breast cancer,
Correct.
right? Okay.
Correct.
Awesome. Now, I wanted to ask you about, I remember when I was watching Oprah, I saw this thing about bioidentical hormones, right?
Yes.
It was a thing at a time. Like, what are bioidentical hormones? And the way they were talking about it is like it's so good. It's best for you. So what are bioidentical hormones? Is it a good thing for you? How does it relate to other kind of hormones? What should people be taking? Compounded hormones versus not?
That is a loaded question, but I'm
Yes.
so happy you asked me. Okay, so we're going to have to go to basic science to understand this.
Okay.
Bioidentical basically means that a hormone that is being prescribed to you is still made in a lab. Okay, it's still lab made. So
Okay.
it's still not, completely natural, quote unquote. But the molecular structure of that product is identical to what our body is producing. So when we're talking about bioidentical estrogen or bioidentical progesterone, the bioidentical estrogen is that estradiol that I talked to you about that comes from the ovaries, that potent estrogen. And a
Hmm.
bioidentical progesterone is micronized progesterone, which is an oral form of progesterone. Okay. The What's important for women to understand is that whether you're using a bioidentical estrogen or a bioidentical progesterone versus a synthetic estrogen and a synthetic progesterone, they are equally safe and equally efficacious in treating menopausal symptoms. Okay, number one. So, if you are using any form of hormone therapy, whether it's a bioidentical or a synthetic, it has the same benefits. It's been approved by Health Canada, and all birth control pills that we have in Canada, besides one, are all synthetic estrogens and progesterones. Does
Hmm.
anyone ever blink an eye about taking a birth control pill?
Yeah,
No.
no, it's interesting, but when you think about it, when you use that word synthetic,
Yeah.
it's got a negative connotation in a way, right? And in this part of our life, we're like, we want the best. We want, bioidentical sounds more appealing in a way,
Of
and
course.
yet when you talk to other like health, menopause, experts, they talk about synthetic. So yeah, it's kind of confusing, really.
So like back in the 1990s, when this women's health initiative came out, we didn't even have any form of bioidentical estrogen and progesterone. So the women's
Right.
health initiative was really a synthetic estrogen called Premarin and a synthetic progestin called medroxyprogesterone acetate (MPA). So
Hmm.
that's where that large women's health initiative was. That was the form of estrogen and progesterone that was used. Compounded products really came into play when the Women's Health Initiative made it sound like hormone therapy was very dangerous. And so the women who wanted to continue to use hormones were getting it compounded because there was no other way of getting their prescriptions because the general family doctor, the general gynecologist was too afraid to prescribe the hormones that were available at that time. If you remember, about 2 years ago, we had an Ozempic shortage. We
Hmm.
also had a Tylenol and Advil shortage during the COVID pandemic. And so, what was happening is that these consumers who were desperate for these prescriptions were going to compounded pharmacies to get compounded, Advil, Tylenol, and Ozempic. But the question is like, where were those, how were they making those compounded products?
How do you
How
control it?
Exactly. It's not
Yeah.
government regulated. We don't know if it's pure. We don't know if it's safe.
Right.
We don't know if it's efficacious. So the same thing goes for a compounded hormone. It's
Right.
not Health Canada approved. We can't confirm safety. We can't confirm efficacy. We also cannot confirm purity. And one
Right.
one pharmacy to a next may make their product differently. So
Right.
why would we ever want to take something compounded when we have no evidence about its safety? So we have bioidentical estrogens and progesterones, which are Health Canada approved now. We have them now. We didn't have them in the 1990s. We have them today. So,
Hmm.
as a consumer, or as a woman, or as a patient, you have the option to talk with your doctor about using bioidentical estrogen and progesterones, which are Health Canada approved, which are very, very effective. But we still also have synthetic estrogens and progestins, which are also very effective. And I think what's beautiful about my job is that I have a toolbox of safe and effective products that I can prescribe to a patient. Not one size fits all. It's like
Hmm.
having makeup brushes in our makeup toolbox, right?
Different
We
makeup brushes for different
Right,
things.
exactly. So the
Yeah.
more makeup brushes I have, the more I can customize the treatment to that individual's risk profile, to her preferences, to her cost in terms of insurance coverage, and in terms of where she is at in her menopause transition. So I like to see all of these options equal. Nothing is better
Hmm.
than the other. To me, as long as the product has been approved by Health Canada, I have reassurance that that product is safe and I know exactly what the benefits are and what the risks are. And I can then safely counsel my patients and go to bed at night knowing I haven't hurt anybody or caused any undue
Hmm.
harm to a woman.
Okay. Well, that's interesting. Cool. Now, you mentioned something about testosterone earlier, which kind of surprised me. I think you said that it drops about 60, age 60.
Right. Yes.
Now, even for myself, people get a blood test and it's like, oh, your testosterone is this. And then you're put on, you know, compounded, testosterone. And then you're told testosterone is important when it comes to libido and stuff like that, right? Muscle
Mhm.
mass. Now, my question is, I have a lot of things going through my head, but with menopause, is it normal or typical to do blood tests to determine, oh, this person is in menopause versus not?
Okay, so it depends on the woman's age. Okay.
Okay.
A woman who is above 45, who is skipping periods and or may have gone for 4 months without a period, and she's over 45, there is no need for any hormone level testing because we know that this is just likely menopause and you are in the average age for a woman to go into menopause.
Okay.
However, if you are under 45 and you are now skipping periods 3, 4 months in a row, that means that there's something else going on. So, are you pregnant? Do you have thyroid dysfunction? Do you have a prolactin secreting tumor in your brain? Or are you in menopause? And if a woman has all blood work done, including hormone levels, which confirms that everything else is normal, but her estrogen levels have dropped significantly and her follicular stimulating hormone or FSH is elevated and she's under 45, then at that point we would diagnose that woman in early menopause. And it's important for us to diagnose early menopause because if a woman has gone into menopause under 45, that is very risky for her in terms of long term consequences.
Right.
Osteoporosis, early onset heart disease, dementia, and also worsening genitourinary syndrome of menopause. So, in easy terms, 45 and above, no blood work needed. 45 and under, yes. And that's because this is considered an endocrine deficiency. You're not supposed to go into menopause until over 45. You need your estrogen for your brain health, your heart health, and your bone health.
So if they are going into menopause early, would that be a good time for hormone replacement therapy then?
It's actually part of the guidelines that women who go into menopause under 45 are are actually recommended and should be on hormone therapy, not only to treat the symptoms of early menopause, but to prevent the loss of the function of your health in terms of the heart, bone, and brain health. So you need to be on hormone therapy until the average age of menopause, which is 51, if you've gone into menopause under 45.
Right. Okay, cool.
Mhm.
Uh, Now, somewhat related to the question I asked before, I want to talk about sex, fertility, and pregnancy.
Okay.
Fun stuff, right? Can you get pregnant when you're in perimenopause?
Can you get pregnant when you're in perimenopause? Absolutely. In fact, we still recommend considering contraception for almost 1 to 2 years after your final period because you never really know when you could randomly ovulate.
Right.
So the risk is always there, even for a 49-year-old woman. So the answer is absolutely yes.
Yeah. I asked that intentionally because, yeah, it can happen. And people think, oh, I'm in perimenopause. I'm safe. No, you're
No, no,
not.
no, not at
You
all.
know, yeah. And, some women have an IUD. Obviously, that's a different situation. But yeah. Okay. Now, sex, it's so important. And I think it's necessary. It's meant to be enjoyable and help women to maintain healthy relationships, right? But of course, we talked about, vaginal dryness. What kind of things can help in this regard so that people, like women, can maintain healthy, intimate relationships during this time?
I think the first thing is that women um, don't have the time to make their relationships a priority. I think
Or make that time.
that's a big thing that I see, which
Mm,
then means that there's a lack of connection between husband and wife or partners,
mm,
and that then leads to a decrease in intimacy and intimate encounters, which then causes more distance between that couple, and it's sort of a self-perpetuating situation. If a woman and her partner are regularly intimate, that increase in blood flow to those vulval vaginal tissues can actually really help minimize the worsening of the genitourinary syndrome of menopause. But regardless of the frequency, we do know that there is a notable change in the physiology of the tissues of the vulva and the vagina. We have estrogen receptors in our vulva and vagina, and we also have androgen receptors as well. And the
mm,
best way that I can describe this to a woman is that when you are premenopausal, your vagina is like a pleated skirt. There's lots of rugae, so there's lots of bumps and kind of hills and valleys on the internal vaginal tissues. It can stretch, it can accommodate, and it's elastic.
mm,
When a woman goes into menopause, your vagina turns into a pencil skirt. There is a loss of the ridges and valleys. It becomes very narrow, it's very tight, and there's no longer any elasticity.
mm.
So think about having intercourse with a pencil skirt. It's very, very difficult.
That's a visual. Very hard, yes. Oh,
And
I love
so
it.
we want to ensure that we keep our vaginas estrogenized. We want to ensure that we keep our vaginas acidic because what happens is there's also a change in the pH. And we also want to keep our vaginas elastic and lubricated for many reasons. And so we do have very, very effective treatments to do this. In the Canadian guidelines, we talk about both lubricants and moisturizers.
Mhm.
Lubricants to me is like makeup. It doesn't really, it covers it up, but it doesn't really provide any long term benefit.
Okay.
Moisturizers we use on our face for hydration. We need to use vaginal moisturizers in our vagina for more hydration as well.
Mhm.
And then the vaginal estrogens is like the vitamin A or retinol for our skin. It's the
Mhm.
anti aging product to keep our face healthy. We use vitamin A. To keep our vagina healthy, we use estrogen. And then there are different forms of estrogen products. We have creams, we have inserts, we have ovules, we also have a small ring, and we have one oral formulation in Canada as well. So there are lots
Mm.
of treatments that women can access. I think there's a fear around hormones again, but what I really want
Yeah.
to reassure women about is that the form of the different vaginal estrogens that we have in Canada, they do not enter the bloodstream. There is no systemic absorption, and they are very, very safe. They can be used for the rest of a woman's life.
Okay. Are we hearing this? Vaginal estrogen. It's good. We gotta keep those vaginas moisturized.
Yes. And
Yes,
one
I
more
love that.
thing.
That's so important.
the the pharmacy, there's one further barrier. So I've told you it's safe. Your doctor
Yeah.
might tell you it's safe. You then go to the pharmacy, you open up the box, and now there's a big black box warning. Estrogen causes breast cancer. Estrogen causes stroke. Estrogen causes heart
Mhm.
attack, blood clot. I want all women to take the black box warning paper and rip it up in half and throw it in the garbage because that black box warning is really related to systemic hormone therapy, not for
Mm.
vaginal estrogen, not for local therapy. So there's a huge issue with the FDA in the US and Health Canada in keeping that black box warning with all forms of estrogen, but they are very, very different products. So I
Hmm.
really want to ensure and reassure women that you can safely use vaginal estrogen until you're 100 years old.
Okay, cool. Now I'm going to come back to testosterone and decreased libido because remember I did message you, and the reason I messaged is because somebody asked me that question. Like
Mhm.
talking about their muscle mass, and they checked their testosterone, and their testosterone was low, and she's in her 40s, right?
Yeah.
So and then she was prescribed a compounded thing. Now I know it's supposed to help with decreased libido. Where do you see a role for testosterone in this process, if at all?
So, as you know, women's health and women's health research is very, very underfunded. So, I am sure, having been in this space now for over 10 years, that there is still a lot of research and things about hormones that we are still very unaware of and we
Hmm.
still haven't uncovered. When we look at the studies that look at the use of testosterone, what we can tell you at this point is that it's only really indicated and has good clinical data based on randomized controlled trials that it's very effective in improving libido. There's
Hmm.
also a very, very big placebo effect with testosterone as well. Dr. Susan Davis is a leading researcher in Australia who has done several podcasts about testosterone in particular. I've heard from influencers on Instagram about testosterone being used for energy, for fatigue, for muscle mass. And maybe they are right, but we don't have the large clinical studies and data to be able to prove that at this point.
Hmm.
So, when you are providing evidence based care, as you do as well, we
Hmm.
have to follow what the guidelines tell us and we have to follow what the research that we currently have are to help guide care for women. Maybe in 10 years, we'll have very different information. But
Hmm.
right now, we don't have that knowledge to be able to appropriately and safely prescribe testosterone for every woman with fatigue or for wanting to maintain their muscle mass.
Yeah.
The other thing with the testosterone levels is I order testosterone for women who are in their 30s who may have PCOS. I
Hmm.
order testosterone levels for women in their early 40s. I've seen people have ordered in their 50s. And can I tell you, those testosterone levels don't really differ between the 30-year-old and the 50-year-old. So when you are getting a blood test at 50 and it's like quote unquote low, who knows what it was when you were 35?
Hmm.
There is no normal range for a woman, but what we do know is that there was a study that Dr. Susan Davis did that looked at drawing testosterone levels, total testosterone levels for women in their 30s, 40s, 50s, and 60s, and the number stayed very much the same on a large scale number of women up until they're 60. So we cannot use a single testosterone level to say, you have low testosterone, we need to replace that.
Yeah. And that's interesting. And it is difficult for people that are out there because I feel like even amongst medical people, there's varying information, right? And
Yes.
varying agreements. So if we even can't be unified in that agreement, how do we expect our patients to, you know?
It's very, very confusing. And all I can say to you and to the listeners is that, women's health research is so underfunded. We
Yeah.
don't have the money to do these large clinical trials to help guide us in terms of whether or not testosterone should be included as part of routine hormone therapy for women. We don't have that knowledge. Maybe it'll come, maybe it won't. But what
Right.
we do have is the information we can use and help provide therapy for indications that we have for it right now. So
Yeah.
I do feel limited sometimes where I want to do and offer things to patients, but if it's not clinically proved, am I causing harm? We don't know what the long term effects are. And even the data that we do have on testosterone is really for only up to 2 years of safety. What about after 2 years? We don't know.
Right. Right. Okay. So we got to treat symptom based, right? And
Mhm.
interesting. Okay. I want to move on a bit, but I feel like I need to mention this. Now there's naturopathic space, and I'm very careful with that because that is not my field. But I do want to talk about something called the Dutch test,
Mhm.
where I know that people use it. People pay hundreds of dollars for this Dutch test to tell them about FSH. But this is something that can be ordered and covered by, well, here, AHS, if it's necessary.
Mhm.
Can you comment on that at all?
I have to say that in a space and in a time where women feel very dismissed by the healthcare team,
Mm-hmm.
our entire family doctors who are currently practicing, we don't get any menopause education. So when a woman is going to her doctor and asking about her menopausal symptoms and getting no answers, I mean, she has every right to say, like, come on, there's more, there has to be more to this than what you're telling me. So then
Right.
that woman starts Googling and looking for other opportunities to understand what's going on with her body, as she
Mm-hmm.
rightly should. The problem is that women may not be able to determine if something that they're being told is based on any true evidence or not. When we do kind of these Dutch tests or these salivary gland testing, they are very expensive tests. And the
Yeah.
problem with these tests is that they are not based on any clinical information that we can actually interpret.
Mm-hmm.
When we are in perimenopause and women say, hey, I want to get my blood levels checked to see if my hormones are in balance, that means that makes no sense to me, because your entire hormonal um, period and cycle is a constant fluctuation in hormones
Change from day to day.
today. So when you're doing a hormone level test, it's telling you what's going on that one particular day. And
Snapshot. Yeah.
exactly, and we don't treat based on numbers, because if we did, we'd be chasing numbers all day long.
Right. Yeah.
So we're treating it based on symptoms.
Symptoms.
And I
Right.
really want women to understand that some of these tests can be very expensive, but they have no clinical meaning. And so it's not, and it makes sense if you look at the physiology of the menstrual cycle and the physiology of what's going on in perimenopause, it would make sense to not do any kind of hormone test because it's fluctuating.
Right. Okay. Yeah. That makes sense. Now I'm going to pivot a bit, and on your social media, which we'll have you mention later, you
Yes.
you show up. You talk about your fitness journey, right? And I mean, you just came back from the gym, still looking gorgeous. So what role does nutrition and exercise play in managing menopause symptoms
Everything.
and mood?
Everything.
Yes.
I cannot emphasize enough that our lifestyle choices have such an impact on how we age. And one thing that I, kind of share with patients sometimes is that if you take two women in their late 20s or early 30s, and one is going to the gym, eating really clean, sleeping well, not consuming alcohol, and you put another woman who may not be doing all of those very rigorous, limited but very important lifestyle choices, you
Mhm.
likely won't be able to tell the difference between those two women.
Mhm.
Fast forward these exact two women 20 years later into their 50s, you will know exactly which woman is which. And so the earlier we make these changes and the earlier we instill some of these really, really important lifestyle choices and health behaviors, the better we're going to do in terms of our menopause transition, in terms of our weight, in terms of our mental health, in terms of our bones, in terms of our muscle mass as well.
Mhm.
So, as I mentioned earlier in the podcast, women never make themselves a priority.
Right.
And, after we give birth, everything happens, or after we get married, like everything revolves around our careers and our families. And so it's really easy to kind of fall off the bandwagon. And then when you add the hormone changes on top of it, it really accelerates some of those changes that we weren't otherwise facing when we were younger.
Yeah.
So for me, when it comes to diet and nutrition and exercise, the research is very strong in a couple of things that I share with all my patients. When it comes to exercise, skinny is not sexy anymore, strong is sexy,
Yes, I
which means
agree.
which means being skinny in your 30s is beautiful. Being skinny in your 60s or 70s means frailty, means fall risk, means bone loss and muscle mass loss, right?
Right.
And so we need to be optimizing our muscle mass as early as possible by strength training, lifting heavy weights regularly, and building that muscle and maintaining that muscle so that we don't end up frail as we get older.
Yeah.
In terms of dietary changes, we always talk about limiting our caloric intake so that we stay thin, but that's not the way to go. We need to feed our bodies, but what we need to feed our bodies is good nutrition. And that means high amount of protein, a high amount of fiber as well.
Mhm.
But when we are tired, when we have hot flushes, when we're moody, we can't sleep, none of this works. So,
Yeah.
my job is to improve a quality of life for a woman by treating her menopausal symptoms, making her feel better, and then allowing her to be able to optimize making some of those positive health behaviors. I can't tell a woman to exercise and eat protein when she can't function because her menopausal symptoms are taking over her life. It's not fair.
Yeah, for sure. But yeah, I completely agree with what you said. And I want to just emphasize again, even mentally, just the
Oh, yeah.
benefit of that's so huge, the benefit of exercise, and not just, people think of exercise, I'm just going to take a walk. Take a walk. But I think strength training is so important too.
I
Like
love
it's,
feeling strong. I don't know.
yeah,
I've never strength trained in my life until the last year and a half.
I was wondering about that.
I
Wow.
I hated the gym. I
I
hated
love
the
it.
gym when I was in junior high. I couldn't wait for my last gym session, my gym class to end. I just hated it. And I was scared. I was so afraid of being judged or I wasn't doing it right or
Get a
you know,
trainer.
honestly, people ask me about that. I really really think having a trainer is so important.
Yeah,
Yes, it's expensive, but the investment in your health, I don't know. I think you're
invaluable.
putting your money into your health, you can save yourself pills later on.
Yeah, no, I completely agree. I strength train, gosh, 3 to 4 days a week. It's
That
just
is so
it's my mental
important.
health.
Yes.
It's my mental health, right? And you think of it, and the more I think, the more you do it, the more you get accustomed to it, right?
Well, you kind of get addicted to it, I think. I have.
Yeah. Well, good for you. And I really hope that people take something out of this and do that. This is so important. Now, in terms of people looking, getting information, there's so many resources out there. Where would you say that people can look to for resources? And maybe while you're answering that, we talked about the menopause, the NAMS certification.
Mhm.
How do you get that? How many people have it in Canada? Where can people get good, sound information about menopause?
So menopause.org is the American Menopause Society. It's called the Menopause Society. The Menopause Society in the US now. They have a wonderful updated website. They have a whole patient section. They have patient videos where they're like 5-minute videos, and they have an interaction between Dr. Marla Shapiro, who's the past president of the Menopause Society, and she interviews a various number of experts, and they're very practical, very short, and evidence based. So you can get a lot of information from there. The Canadian Menopause Society, we also have a website and a patient section as well with some articles and publications. Another place I'd love to send women is the Menopause Foundation of Canada, which is an advocacy group really helping to break down the stigma of menopause. They have symptom trackers on their website. They have a guide as to 1, 2, 3 how to prepare for your doctor's appointment. And they have a lot of other resources on that website as well. And finally, when it comes to the actual delivery of hormone therapy and menopausal care, the mq6.ca website is the number one website that I send both patients as well as healthcare providers to. MQ6 stands for Menopause Q Quick 6, and
Mm,
it's a 6 question validated questionnaire that healthcare providers can ask of their patients when they're coming in with menopausal symptoms. And then, based on the questions and the patient's history and risk factor profile, it actually has an algorithm that kind of walks you through whether that patient is a candidate for hormone therapy. And it also gives you some suggestions on what to start with,
yeah.
which is brilliant. So I love that website. It was developed by one of my colleagues, Dr. Susan Goldstein in Toronto.
Number 6 or SIX?
Six. MQ number six
Number
dot
6.
ca.
Okay, I'm going to put it in the notes. That's awesome. Okay, well, that's good to know. Really good. And I love that it helps women know, empower them with information so that when they go to their primary care physicians, they know what to say and
Mhm.
how to have that conversation. Awesome. Now, a lot of people are getting information off not conventional media, social media. Where can we find you? And who are people that you think are great or in terms of this field of menopause in that world?
So my Instagram handle is Dr. Shafeena Premji. I have a love-hate relationship, Dr. Ify, with social media. I sometimes I'm like, am I actually helping? Am I not helping? Should I be putting more information out? Is this going to be more confusing? Is it even valuable? I do go through the backs and forths about this, and I just never know what the right thing to do is.
I
Um,
do too, but I think somebody that's as knowledgeable as you do make a difference. Well, I can tell you that you certainly do make a difference. And if not you, there's a lot of other people out there that are speaking and spreading the word that should not be spreading the word. So I
Yes.
would rather that people go to, people like you that know what they're talking about. So absolutely does make a difference.
Thank you. I appreciate that. We also have the Canadian Menopause Society Instagram page as well. The Menopause Foundation of Canada have an Instagram page. And in terms of evidence based menopause practitioners in the country, in Canada, we don't have a lot of them.
Mhm.
But the ones that I do know, I can share with you. So, as many of you may or may not know, Dr. Jen Gunter is an American gynecologist who's written several books, and she is actually Canadian and moving back home. So she's got
Right.
a really strong following on Instagram. A couple of my colleagues, Dr. Ardell Piper is a gynecologist in Ottawa, and Dr. Allison Shea is another gynecologist in Hamilton, Ontario. They both have Instagram pages where they do a lot of menopause advocacy.
Cool.
And then I have a couple of family doctors as well. So I have Dr. Sheila W., who is
Love
based
her.
in Toronto, and she is doing lots of advocacy for women's health, equity, and diversity. And then there's also another Instagram page called It's Our Time Canada, where
Yes.
there are three physicians who are opening a menopause clinic in Toronto. And they do a lot of menopause advocacy as well.
Okay, awesome. And I know that Dr. Sheila, this is somewhat newer in Canada than the States, but I mean, she just, with, another colleague started a podcast, the Doc.
Yeah, Dr. Shasma Matani,
Yes.
the Doc Pod,
Talk
Doc Talk podcast.
podcast. Yeah, it's a tongue twister. Doc Talk podcast. So I'm giving it a shout out here for people to follow, and it's good information from board certified physicians. It's really
In
good.
Canada. I think
In
that's
Canada,
in
yes, because
Canada.
medicine here is so different from the States, right?
Yes,
Yeah, so
exactly.
awesome. Now, final words. Knowledge is power. Want to make sure that people get reputable information. Do you have any final words? Did we not touch on? What did we not touch on? I think we covered a lot of things.
I just want listeners to know that even though it may take 2 years to get the help that you need, which I'm sorry for that, I apologize on behalf of our healthcare system that sometimes your journey may end up taking 2 years. I really just want to highlight to women that you are worthy of speaking up and advocating for yourself, because even though there is a limited number of menopause specialists in the country, we genuinely care about your health. We genuinely care about your quality of life. And menopause is a midlife event. This is not the end of your prime life years. You have so much to offer the world. I applaud you for the wisdom and experience you have as a mature woman. And I'm really here to support you in your journey using the evidence based therapies that we have in Canada to optimize your health. So please advocate for yourself, be a CEO of your health. Don't give up. You are worthy, and we are here to support you. That would be my message.
Amen. I love it. I love it. I love it. I love it. So I want to thank you so much. I know you're a mom, you've got two boys, your wife, you're an artist, you've got clinics, you're so busy, and you've made this time to talk to us today. And along with your other colleagues, you're sharing knowledge and breaking down the stigma on menopause. And so I want to thank you so much for this. It's really, truly an honor to have you as a guest on my podcast. And I'm truly thankful for you doing this.
Well, I have to say, I'm so happy that we found each other, but I'm
Yes.
even happier that we're both in Calgary,
Yes.
and we're also ethnic minorities.
Yes.
And so I think that this movement that we are doing for women is so important and so vital. And I just, it takes a lot of work to start a podcast, to edit, to find guests. So I just really want to applaud you for the work that you're doing, because I am confident that your podcast is going to have a significant impact on our community and our society. And I know that the guests you're going to bring are going to be very valuable speakers to enhance the care of women. So I want to say thank you to you.
Oh, well, thank you to you as well. Now, I want to thank our listeners as well and to tell them to remember that this is informational and educational. You need to see your doctor for any symptoms that you are having. And I want to end this episode in the words of Maya Angelou. She says, as women, we have the power to shape our own lives and create the future we want for ourselves. So let's continue to support one another and empower each other throughout all stages of our life. Thank you so much, Dr. Premji, for being
Thank you,
here.
Dr.
It really
Ify.
is an honor.
Thank you.
Awesome. Thanks for being a guest on my podcast, and to everyone that's listened, a huge thank you to you as well. I look forward to sharing the next episode with you. Please follow me on my social media platforms at Dr. Ify Women's Health for upcoming episodes and more. Please note that the discussions and opinions shared in this podcast should not be considered medical advice. If you have any concerns or symptoms, please consult your primary care physician.